So, first, actually, I would like to call our respected Dr. Basin sir from Gwalior. Actually, he is the very eminent surgeon, eminent consultant from the Ratan Jyoti of the Gwalior, and he's my mentor. Always, actually, I promote me and always support me. So, actually, he's talking about the traumatic subluxated cataract surgical pulse. So, over to you, sir.
Mic is not working on the other side. Monica. Uh, Very good morning. Um, Really, it is a bright morning, and ladies on the dais, and few chairs occupied by the speakers, and rest of the chairs smiling on us. So that is really beautiful morning, and it's a very intricate subject, traumatic cataract. So I really appreciate Dr. Rakesh for choosing this subject, which is very close to my heart. Yeah, which is very close to my heart. Traumatic subluxated cataract. So I am Dr. Purendra from Gwalior, and I am very happy to be part of this course. And Rakesh is my favorite from all over the country. Thank you for including me to this course. So this is a video. I will be showing only the videos. This case had a trauma, blunt trauma. The lens is subluxated, and there is a presence of vitreous in the anterior chamber. I'm, I have stained the vitreous by the triamcinolone, diluted triamcinolone, and I'm making a capsular axis. The important thing which has to be kept in mind is that capsular axis should be made central to the lens, and hydrodissection is done, and a capsule retractor is placed. Now, this is a very soft lens, as you can see. Young patient, you have to fill the chamber with viscoelastic before you come out, or your irrigating handpiece comes out in, as you can see, twice I have banished that. So now, after doing the cataract removal and polishing the capsule, I make a tunnel in the area 1.5 to 2 millimeter away. This is a reverse tunnel. I make it on both sides, and 27 gauge bent needle is passed through it. So I have removed my capsule retractor so as to make a space to pass this needle, so which is not going to damage, and I am guiding the needle hub, which should not touch the thin capsule while bringing it out, because it turns inside and it can rupture the capsule. This is a Sioni ring, and proline suture is tied to the haptic of the Sioni ring, and it is pulled to the area of maximum zonal dialysis. So this is how the Sioni ring is tied to the sclera, and the proline suture knot is buried in the scleral tunnel. So I am removing the viscoelastic from the surface, and from the anterior chamber. At the end, again, I have stained the capsule, the vitreous, and did the anterior vitrectomy. Now, there was a traumatic mydriasis. So, with the vitreous cutter itself, or you can use the eye irrigation aspiration handpiece and reduce the size of the pupil. So this is how I've decreased the size of the pupil, and vitreous has been removed. No tags of vitreous in the anterior chamber or in the wound, and the lens is very well centered, and the capsular bag is also stable. So this young patient will definitely will have a good vision for the long. This is a grossly subluxated cataract. As you can see, I am making the scleral tunnels on both sides to bury the proline suture knots. Capsular access is done. So one more thing which is important is that you should have a broad anterior capsular rim to support the capsule retractor. Otherwise, it was going to slip out. Removal or doing phacoemulsification is simple. So this is a double Sioni ring, means there are two extra haptics 180-degree apart, which has to with and this ring will be supported at two places. You can use this ring, which makes the surgery a bit cumbersome, and or you can use one capsule CTR with a single haptic, uh, or along with a CT segment. So that also can be done. And this was a grossly subluxated lens, more than 180-degree subluxation was there. So that is the reason why I chose to put a double Sioni ring in this particular case. So this is the post-op picture of the same patient. This is very interesting case. A 32 years old lady came to me, and she was complaining of defective vision since last 9 years. On examination, her vision in right eye was 6 by 6, but in her left eye, her vision was improving to 612 by this myopic correction and myopic astigmatism of 4.5 diopters. So someone has advised to go for the cornea based refractive procedure. So, but on pentacam, on topography, I found that there is no cylindrical power which is there. Why she had a cylinder? So we dilated the patient, and on dilatation we found that there is a nucleus sclerosis and posterior subcapsular cataract. Along with this, there was a subluxation of lens. So retrospectively, when I asked her, she gave the history of trauma 11 years back before her marriage. So then we planned for a laser based cataract surgery assisted and phaco with the Sioni ring. So this is the area of zonular dialysis, as you can see in this picture. This is the area of zonal dialysis. So I am making a 4.6 millimeter wide capsular axis, and which is made eccentric, and this is very very important. And with this catalyst machine you can center the capsular axis, and in subluxated cataracts, when it is dense or mature or hard, doing the capsular axis is the most challenging part, because the anterior capsule is lax. It is not very stiff as you see in other cases. In this particular case, you see, I didn't go for any CTR, because there was a area of 2 or 3 clock hour zonal dialysis earlier. So there was a vitreous strand which was coming. So the rest of the surgery was done by the vitreous cutter, and we did the vitrectomy, anterior vitrectomy, along with the cortical aspiration. Then I placed the Sioni ring, so, and the lens was made central, the capsular bag was made central, and this is how we rehabilitated. And post-operatively, with minus myopic correction, her vision improved to 6 by 9, and this post-operative picture shows the well-centered lens. Another case, grossly subluxated lens managed in a similar way. One last case I would like to show, because this is a long-standing subluxated lens. So this 60 years old male patient came to us, and he had a trauma um, around 20-30 years back, and since then he didn't bother for it, and now he came for the cataract surgery. And you can see long-standing subluxated lenses, they get deformed and shortening of the back occurs. So we used two capsule retractors, my same technique, making a tunnel, and 90 proline is tied to the haptic of the Sioni ring. Now in these cases the lens bag is small, so passing a Sioni ring in the lens bag is very very challenging. And as you can see, the pupil has also come down, and I'm using a bimanual technique, and throughout the lens, the anterior chamber should be filled with viscoelastic. So, I'm the curvature of the Sione ring is, pulled towards yourself by one Sinskey hook, and then with the another Sinskey hook, you dial the Sione ring into the capsular bag. So the Sione ring is tied to the sclera, lens matter is removed. So my take-home message is that Sione ring should be placed whenever it is necessary, whenever you feel that it is necessary to stabilize the lens bag. Because once the lens bag is deformed or destabilized, you cannot do anything later on. You have to convert into the removal of the bag and then SFIOL. So this is managed by scleral fixated IOL, and you can adopt any technique, whichever is convenient, whichever way you are convenient, Yamane technique or iris fixated lens. So it's not moving. आगे नहीं जा रहा इधर आ गया. So to conclude, using iris retractor or capsule retractor at the capsular access margin is very good, and it stabilizes the lens bag. It works like the zonule, and because it pulls towards the periphery, the lens bag. More the zonular dialysis, more the number of capsule retractors you have to place. More than 3 clock hours zonular dialysis, use a modified CTR or a Sione ring. Use CTR as early or late as necessary. This is a very, very important thing to be remembered. Ideally, after cataract and cortical removal, CTR, Sione ring, CT segment in the bag facilitates long-term safety. One should be prepared to convert to SFIOL, ACIOL, glued IOL, or iris fixated IOL. I thank you for your patient hearing. This is the Gwalior Fort. It is very good to be watched. Dr. Vinita, if you have not been to Gwalior Fort, so I. So
So
thank you.
it's very nice and everything is explained properly. So, sir, I have the sub few question you allow me to ask.
Sure, sure.
So, actually, you stand the capsule with the triamcinolone. So, why actually didn't you use
It was
the?
not to stain the capsule. It was to stain the vitreous because there was vitreous in the anterior
Okay.
chamber, and in the area of zonular dialysis, the vitreous was in the anterior chamber.
If there is the dialysis, it's slightly more. So, if you want, if you actually stand the capsule with the preferred blue or not. Sometimes the dye is gone on
I
the
know,
back side.
but
So, why?
if the visibility is poor, you have to use trypan blue because our first aim is to have a good capsular access. If your capsular access is gone, the whole procedure you cannot do anything after that.
Actually,
You are
sir,
gone.
I actually dilute the dye in sometimes because when the dialysis is more. So when you put the very concentrated dye, it can
It
always
goes
go
with.
behind it. So why this reason I always diluted,
So
and only the one drop or two drop I used actually.
no, no, that is good and a good suggestion. But what in such cases I do is I plug the vitreous with the viscoat in that region. I go there, plug the vitreous with viscoat. So because the dye will go from that area, from the area where the zonal dialysis is there,
Yeah.
it is going to go behind from there. So if you plug it with viscoat and don't fill the chamber, just plug that area only, and then you stain that capsule, and that will not a minimum amount of dye will go behind then.
Sir, and
Mike. Yeah, it is going to prevent further, no? Ah, yes, sir. You are right. No, red glow will be affected. Uh, oh, yeah. It doesn't make any. Yeah.
It is there means happens mostly
Mo-
with us where we are doing DM stainings lot of times in DMD in complicated cataract. So it is possible ki dye goes behind the
but
vitreous, but I
only
think
thing,
it is harmless.
red reflex is affected. Rest the technique will remain the same.
sir, another thing is that you actually use the Sione ring. Sometimes when we use the Sione ring, it can cause the progressive jonulopathy during the dialing, the lead and trailing end.
It's
So if you actually use the CT segment instead of that, so what the advantage or disadvantage of this type of?
it's very good question. I I will say that whether you are using CTR, capsule tension ring or CONE ring, chances of extension of the zonal dialysis is very high in all the condition. What is very very important is for this that your capsular bag should be distended nicely with viscoelastic. If the capsular bag is not distended well, because the tensile strength should be there in the capsule bag, so then it will rotate inside the bag. If your capsular bag is not filled with viscoelastic, you are bound to damage the capsular bag. The ring will perforate and it is going to go behind and
Okay.
it will not dial. So that otherwise, it's not. I have had a problem with the CTR so many times, and so it will not go. So that is what is the distension of the filling of the capsular bag with viscoelastic is very very important.
And sir, last case you actually make a capsule access with the flex.
Ah,
Uh,
couple of
so why, sir, it use actually every where that is not possible?
No, but if you have that, so you should do it, because the most difficult thing in these procedures is
Just,
the
yes,
doing
sir.
the capsular access, and more so there are so many cases you have also seen and others are also facing, where you have to do capsular access under the iris. You have to go under the iris and then you have to complete it. So in all these cases, and when the lens is intumescent, when the patient is apprehensive and not very cooperative, so it is always wise to adopt a safe technique, and it is recommended in textbook also that in subluxated cataract, in hard cataract, the femtolaser assisted cataract surgery is better, and it is indicated in such cases also. And I feel it is very very good.
because it will give less stress on the zonule while you are doing capsular access. It will give a less stress because it will not
You are not
enlarge
pulling,
the
yeah,
your dials, because already you have, and you can center it
yeah.
in the back. You can capsular
That's what.
stuff like that. You can center it on the.
Hi, that's what I showed. You can bring it wherever you want, where the lens is, because the most important thing in subluxated cataract is the centration of the capsular axis, which you are doing. So that has to be very nicely done and kept in mind while doing the capsular axis.
I would have two small questions. First, do you use capsular tension ring in any case of suspected subluxation, even even if it's a small angle subluxation,
Yes.
you will use it?
Yes, it should be done. It should be used in all cases of zonal dialysis, whether it is less than 3 clock hours. Still, less than 3 clock
Yeah,
hours, I use CTR. More than 3 clock hours, I use
the
Sione
ring,
ring.
the ring.
Yeah, and in all cases, I do, because you never know, the whole lens bag gets shrink
A
with and
shrinkage of
fibrosed
the,
and
yeah,
decentration of the lens. And now we with the premium lenses, the centration of the lens is very very important.
yes.
It has to be kept in mind.
And the other question, do you prefer femto in all cases of subluxation? Yani if I'm planning of a subluxated cataract surgery, I should go with the patient a place where femto is available, or cautiously will do the capsular access. Which do you prefer?
It is your choice and the patient's choice in our country, because they
Yeah.
have to pay for it. I will prefer doing it with the laser, but if the patient is not willing, and then we do it with the
With the
manually, and
precautions.
manually also it is possible and can be done.
Thank you.
Thank you, sir. Thank you, sir. Nicely
Thank you.
covered. And now I would like to call Dr. Gautam Singh Parmar. He is the consultant of the cornea and cataract in the from Chitrakoot. And actually, he is doing a very well versatile surgeon. And actually, many things I actually learned from the Gautam.
At the outset, I would like to thank a scientific committee as well as especially special thanks to Shakya sir for including me in this instruction course. So I'll be speaking on the traumatic cataract with corneal trauma as well as the iris trauma. So traumatic cataract is always a challenge, as we know all. The outcome is usually unpredictable, especially if the lens and iris trauma is there and posterior segment involvement. So what we do, the restoration of anatomy and function of everything is the primary goal in such cases. So if tear comes with cataract, and always there is a debate whether to go for cataract surgery simultaneously or put IOL simultaneously. So a lot of factors can decide, like anti-capsule is ruptured or not. If it is ruptured, then definitely we should remove the cataract. Second thing, visibility, which is a big issue, because initial traumas, we know that there are a lot of corneal edema as well as opacities. Visibility is a big issue, and it makes you whether to put IOL or not. Then IOL power calculation, its centration, because pupil is not, sometimes the rhexis is not complete, and in-back placement is also not possible every time. And again, if it comes late, then posterior synechiae or complete or partial closure of sulcus. These are the issues which plays a role while deciding whether to go for cataract simultaneously or later, or how to do it. So here is a case, a 37-year-old young male. In his right eye, there are wire injury and with anti-capsular trauma. So we decided cataract corneal tear repair at the same time, and since the anti-capsule was ruptured, we did cataract extraction also. Unfortunately, patient presented 1 year after the primary surgery, where you can see there are posterior capsular, remaining posterior capsule is opacified, and iris is very firmly adherent to the area where the tear was repaired. And at many places, the iris is fused with posterior capsule also, and there is complete or partial closure of the sulcus also happens. So it presented 1 year, and we decided to plan secondary IOL implantation here after IOL power calculation, and along with the pupilloplasty to make it roughly circular and avoid the complications of that. So here is the video. I just making side ports, and then I try to release the synechiae, but it is very firmly fused. So I use micro scissor to cut the synechiaes both sides, and in the tear area it was completely fused, so no question of deciding it. So then I did this capsulotomy using my vitrector. The settings of vitrector is very important here, and you should avoid the iris trauma by retracting the iris as I am doing it here. And I did complete vitrectomy. Now I decided to make slight anterior tunnel, because here everything is fused. So I didn't make a scleral tunnel, but a corneal tunnel I prepared. And then I put 3-piece rigid IOL in this sulcus. It is well placed because sulcus was good and support was very good. But now you can see the pupil is not circular. So I first see the stretchability of the iris on both the sides, and then I decided to do pupilloplasty using 10-O nylon monofilament, 10-O proline monofilament. This is long needle. I am passing through the iris both sides, and then I retract the iris using Kuglan's hook. This is very important instrument and must to have instrument, the Kuglan's hook. Then I did 4-throw, single pass 4-throw pupilloplasty. As you can see here, I stretched and then I cut. Now this is the unique thing I did. I repaired this, since this is iridodialysis like picture. So I stuck this iris with the posterior lip of tunnel, and the iris adhered to the posterior lip of the tunnel. So you can see that now it is well opposed. Now I make pupil circular using this cutter, but at the same time I seen that there is a iridodialysis at inferior side. So I did peritomy and decided to repair the iris. So this is my technique of repairing iridodialysis. I put the other end in a 30-gauge needle and take it out. And then I tied it, but since the stumps are outside the eye, so I have a technique of burying these stumps outside the eye. I put a nylon suture like this and make a loop in this nylon suture, and then put this both ends in this loop. And then I pull this. So these stumps were buried, and then I close with the using glue, and then I aspirate the remaining vitreous, and then I hydrate the wounds. So this is post of 1 month picture, where though the cylinder is very high, but its BCVA was 6/12. The IOL is very stable, and pupil size and shape is also quite fine, not that much big and irregular. This is another case There are 49-year-old female in left eye after firecracker injury, and she unfortunately presented 6 months later of the injury, after the injury. Here, you can see the traumatic cataract is there with iridodialysis, and eversion of the iris is there. This is very important to note. Iris is not deficient here, but it is reverted on itself. And there is organized fibrin in the pupil with the irregular pupil. You can see the fistune, very much fistune pupil because of the, and B scan was normal. So we decided to go for cataract extraction with IOL, with anterior vitrectomy if needed, and pupiloplasty and iridodialysis repair if it is required. So here is the surgery. I first made side ports and then filled viscoelastic. Then I remove this reverted iris. You can see that iris is present there, but it is reverted on itself. Then I released the synechias, firm synechias. Then I repaired this dialyzed iris using this technique of Kobler's technique, we can say. Okay, so then I remove the lens, do irrigation aspiration, and cut all these membranes which were there, and then I release the synechia. It is easier to release at this time. Place the IOL in bag, stretch the iris because the iris is dilated and fixed. So I stretched the iris and did pupiloplasty here. As I shown before, I use Kuglan's hook and fourth row, single pass fourth row pupiloplasty here. So this is fourth row I am taking from the loop, and then I tied it. Second suture in this area, and then I repaired this dialyzed part. Now it comes like dialyze. So I repair the dialysis as I told before. It is just like what sewing machine do or a cobbler do. Then I tied the knot, and you can see the iris is well opposed to the periphery. And then I bury this suture as I told before. I make a loop in tenno nylon suture, tie these stumps with the tenno nylon suture, and take it out and cut. And then I give these 3 nicks because this iris is very straight. So I give these 3 small nicks using micro scissors. And I will show you the results after 1 month. What happens after 1 month once we give these 3 small nicks to regularize the pupil. And then I close using fibrin glue. And this is the day 1. You can see at the day 1 there is a zigzag pupil. But after 1 month, you can see here, the pupil is almost curved. So you can get the curvature using these multiple nicks. Here you can see a well-centered IOL with the nearly circular and optimum sized pupil. So to conclude that in traumatic cataract with corneal and iris trauma cases, we should prognosticate first and counsel well to the patient, and adequate restoration of all possible anatomy is vital for visual and cosmesis. Thank you so much for your patient listening.
So actually very nicely presented about the traumatic cataract with iris repair, because in this type of cases it require the integrity of the globe is very important. So but when you do before actually doing the surgery, I think you do the gonioscopy. What about the
Yeah, so surely we are not doing gonioscopy myself, but we refer to our glaucoma department as Dr. Sakya. He will manage and he suggests what to do. But the purpose here is to achieve all the functional and anatomical restoration of everything. And even before we can go for that, and even we can plan simultaneous glaucoma procedure also. Here in that case, it was not advisable. That's why we did only the cornea and cataract procedure. But we can do simultaneous glaucoma procedures also if it is
actually I
required.
saw the after the trauma, actually I saw that there the many synechias are actually form when in the angle. So angle becomes occluded, and it is type of the creeping type of the angle. So by this reason you always refer the patient to the glaucoma evaluation. So this is my, and if you have sir any idea about this type of the cataract, if you have any suggestions, sir, please give.
I think he has managed it very nicely, beautifully. The important thing is that you should remove any vitreous which is present anteriorly, and we should check for the stability of the lens, which is going to be otherwise in such cases when the posterior capsule is deficient somewhere, like in the first case, the superior part where the trauma was, where the scar was, so the capsule was looking deficient. Maybe posterior capsule was present, and in the inferior part you can see, so the dense thickened capsule. Maybe in the upper part, posterior capsule must be
Yeah,
present.
upper superior-temporal it was not there. It was
Deficient,
probably
yes.
fused, but the inferior part is locked with the iris and all this fused, so it is not means it quite stable because of that.
But stability of the lens and any
Yeah,
vitreous,
yeah.
if it is present, that should be cleaned before. And you have already done very beautifully on the management of the iris. And cataract should be managed, removal of all the lens matter should be there. That is what. And you have done a visual access also, you have managed right in the first surgery. That is a good thing which you have done.
Especially the lower and 3 to 9 o'clock capsular support is more important. Upper part
Yeah,
you may,
yeah.
because
Upper
then
part
it
may
will
be
not
managed.
sink.
Yeah, yeah, sure.
And Dr. Binita ma'am, if you have any comment on this.
I think such an extensive trauma, you should have a multi-departmental approach because these patients may have a retinal dialysis,
Yeah,
they
sure,
may
ma'am,
have a
sure.
problem with the retina. Many of the patients, they come with a vitreous hemorrhage, so it's like a comprehensive management of a trauma in toto, where you have not only to give the lens in position, but definitely the good vision.
And I would like also to add in the assessment after doing sonar in this opaque media, UBM, ultrasound by microscopy, and this might save the patient going to glaucoma specialist for the angle. I will see all the data of the iris, the posterior chamber, the intactness of the posterior capsule, if there are remnants, and the degree of remnants of the anterior capsular rents. It will add a lot, I think, in cases of trauma, and it might be an impacted foreign body. In some cases, we documented impacted foreign body in the sulcus or the angle. These are all data, I think, very important to assess. But congratulations for the very nice repair of these iris injuries. Thank you.
Actually, Dr. Gautam is a very fine surgeon in from Sadhguru Nature's Kalai, Chitrakoot. So next time, madam, you visited the Chitrakoot.
Inshallah. My pleasure.
So, so now I would like to call Dr. Binod Singh. He is the associated professor and consultant in Medical College, Prayagraj. And
Good morning, everybody, and thank you to Sakya sir and all these my seniors. They have given the opportunity to present my few works. So, yeah, three cases are there, traumatic cases are there, where there was a corneal tear, and cataract, and with the intraocular foreign body embedded in the retina. So, you'll come to see how I try to manage and give a maximum output.
yeah.
In the first case, a 38-year male, so trauma by the iron nail. There was a corneal tear and cataract with the foreign body lying inside the retina. We can see on the B scan, there is in the mid-vitreous cavity hyperechoic part is seen, and along with the fine echoes with the vitreous hemorrhages. In this case, there was a corneal tear which was self-sealed, so I didn't, and it was in the visual axis, so I thought not to put the suture. But after irrigation was on, we saw there was a leakage. So after that, I decided to put a single suture and make it a closed chamber. And then the remaining cortical matter was removed through a pars plana approach. because here you have a good visibility of the capsule. You can save the capsule. The light is there, and then did the core vitectomy, and here I'm trying to just remove the posterior highlight, inducing the PVD, so that your foreign body is free from the vitreous and you can easily remove it. The foreign body is quite embedded going inside this beneath even the choroid, and you are not able to see the margin of the foreign body. So it's lying behind the retinal tear margin. So it is very difficult to hold these foreign bodies. Even you're not able to getting a proper edges of the foreign body. So while removing these foreign body, you may create more tear and more detachments. Possibility is there. So taking care of all these points, I try to take it out. Even though forceps are not able to grip sometimes, the edges are not so fine. So a little bleed was there because these foreign bodies are so sharp, edges are so sharp, it damages the other structures. So very gently try to take it out, avoiding traumatizing other tissues like cornea and iris. And then after the removal, we found that there was a focal detachment at the site of the impacted foreign body. So then I did the complete peripheral vitectomy and did fluid air exchange and barraged the lasered area and put the silicone oil to just stabilize the retina, and then close these three ports of 23 gauge because oil was there, otherwise no need to put the suture. In the second case, it was around a 28-year boy who was working in a shop of a goldsmith. He was cutting, what we say, gungru from the pile, and it came directly hit his cornea and went inside, got impacted in the lens only. It didn't go behind the lens. On this day, my recording system was not working, so I took it directly from the mobile. My OT assistant tried to record this case. As we can see, there is a very fine serrated margins of this foreign body. So I tried to just rotate it, that the serrated margin, the fine margin should go behind so that it does not create the corneal damage. So with the help of the visco, I try to express it out rather than holding with the forceps. It may tear the iris tissue behind while removing with the forceps. And here the corneal tear was also not in any particular pattern or the train. So I removed the remaining cortical matter, aspirated it with the Simco. This was a pre-operative photograph, and then chamber was maintained nicely. You can see clear cornea. This is the third case. Here again the iron state particle was there. Cornea was repaired. Then patient was referred to me. Nice. Tried to do the rhexis after staining. And then phacoemulsification was done, and in this case the IOL, foldable IOL was placed in the bag, and then from pars plana route I tried removing these old vitreous hemorrhages, and then we were able to locate the foreign body. So case was quite old, around 2 to 3 months, and this whole foreign body was fibrosed. There was a thick fibrosis over the foreign body. So you have to peel it out to take the foreign body. It was big in size, around 5 to 5.5 millimeter. So I removed it from the impacted side and then tried to save the macula with the PFCL, but it was not working. These foreign bodies are so heavy in the weight, so PFCL doesn't work. So in this case, the capsule was saved, so I didn't took the foreign body from the anterior route from the SICS tunnel, so I had to extend the pars plana route. I had to make a big incision here, and it's not very easy even to hold this forceps, they slip. But ultimately we took it out. It was a big serrated sharp edges, and then completed the vitrectomy. Remaining part of the vitreous in the periphery was removed. And then aspirated the PFCL and did a barrage around the tear area. There was a no detachment. But the incision at the pars plana root was so big, so I put the silicone oil as a prophylaxis to stabilize the retina. I don't have a future retinal detachment, and the port was closed with the suture. Thank you, sir. So any suggestions from my seniors while moving these foreign bodies?
So actually, you nicely covered the different type of the foreign body, and because I am not retina person, but Dr. Basin sir actually doing many cases like that. So Basin sir, if you have any comment on this, and Dr. Professor Nihal also.
He has nicely covered everything, and in such a cases, but these are very, very difficult and challenging removal of
Yes,
foreign bodies, because you can traumatize the things further.
yeah, a lot of chances.
Yeah. So because you never know what is the extent and shape of the foreign body. So our wound should be roomy to bring out, and you should be using a good forceps, and variety of forceps are available.
Yes, sir.
As per the size and shape of the
Yeah, yeah.
which we are
Yes, sir.
surgeons they
Yes,
use.
sir.
So you should have everything in your armamentarium, because you don't know which foreign body will be required to hold which kind of which forceps is required to hold the which kind of foreign body. And another thing is that use of PFCL should be there, because many a times it is seen that foreign body falls down.
Yeah, it falls many times
Yeah.
while holding.
So yeah, it is an extra step and extra
Yes.
cost to the patient, but definitely it prevents the damage to the macula and the important structures of the retina. If it is somewhere else, then it doesn't matter.
Yes.
You can barrage it at that area and you can do it. I'm not a retina surgeon, but definitely.
No,
Thank you.
sir. Thank you,
And
sir.
then placing, what I do is my retina person remove foreign body and everything, and after 1 to 3 months, when we do the secondary ION, after the SOR,
Yes, sir.
silicone oil remove, everything is fine. Then we do the secondary ION, whatever the status of the PC is there.
Yeah, during SOR we do the secondary oil, because again we have to go for the second surgery. It's not advisable to do it in first position. Thank you, sir.
Thank you very much.
Any,
Yes,
One
sir.
thing, I'm very sorry I came so late,
No, sir.
but one problem that we always face as anterior segment surgeons, that calculation with the SOR,
Yes.
with the silicone oil inside calculation of the biometry. So
Gee.
that will never be very accurate, number one. Number
Yes,
two,
sir.
obviously because of the traumatized eye, and especially if it has extended to the cornea, so the K values go haywire. So it is also the discretion of the surgeon, if it is possible, removing the SOR, doing the SOR, leaving it for 2 to 3 months, and then finally putting the
Yeah,
intraocular
that will
lens.
give more accuracy, sir.
Yeah.
Definitely.
So basically, it all depends upon the condition, because if it is a traumatized eye with a macula involved, then you know that the visual prognosis is not so good,
So,
and you can do both the things, intraocular lens, in the same sitting.
yes,
However, if the macula is spared and you think the potential of vision is very high, then possibly the accuracy of the biometry is
we
quite
can
important.
implant later on after this one. Yeah.
And for the accuracy of the size and the shape of the foreign body, this needs a good equicker. To a good sonar, to do a good sonar, this is the cooperation with from imaging and the physician to give him the size, the proper size, and I can detect by the sonar the configuration, if it's an irregular, if it's pointed, if it is smooth edges. This all, I think it will help the surgeon to decide and to plan for his section, and also to do electrophysiology in these cases before cataract removal, because if it's an old, it will affect the rod and cone function dramatically, and to know the visual prognosis after surgery by electrophysiology is very important, as just Professor said, of macular changes, macular lesion. And the other point of silicon filled eyes, whatever I feel doing a silicon filled unless some circumstances they don't detect even it is a silicon filled globe, and he will take by the axial length is 32 and it will go over correction dramatically. But unless this is mistake is considered, calculation of the silicon filled eye, if it is plus or minus 1 or 2 diopters for the patient, I think it will go for this is the list. Yeah. Thank you.
Thank
very
you,
much.
thank you, ma'am. Thank you, sir.
Thank you, Vinod. And now I
we
would
use-
like to call. Yeah.
Can we use the magnetic foreign body can be removed with the help of a magnet?
Yeah,
I
I
suppose.
use the magnet after removing from the impacted side. I took the magnet and in the mid vitreous, then I hold it.
Yeah,
Because holding directly from the retina, it will create more trauma.
Thank you, Vinod. And now I would like to call our eminent Professor Dr. Rajiv Chaudhary sir from Indore. And he's the eminent surgeon from the Indore. Excuse me, just
While Rajiv sir is getting ready, so one or two points, if from our cases. So a glass foreign body is again a foreign body that is very different from a metal foreign body, and when we used to do glass foreign body evaluation with the ultrasound, the possibility of the artifacts and the artifact defects had to be taken into account, and we had published at that point of time papers in which the artifacts posed as if they were foreign bodies, multiple foreign bodies, but it was just the facets of the glass foreign body that was actually there. But of course, with the other imaging systems now, the CT and the MRI, that has become much more important. And
You are absolutely correct, sir. Recently, I was reading an article wherein they have missed the foreign body, glass foreign body, in the retina, small glass foreign bodies, and in the first group. And because we do only axial and the coronal section, we make the eye place the general, because sometimes the wound is also there. So gently we just cursory examination is done. So in that situation, it is missed. So later on, we should check it once the repair is done. We should do B scan again, and then we should evaluate the posterior segment if any other foreign bodies are there.
okay,
I
sir.
think it's more wise to do before in traumatology, before the admission even of the patient to a hospital, we used to do an X-ray. I think
Yeah.
now it's wise for these cases not to miss, according to the history of the accident and the methodology of the trauma. If suspected to be, if a car accident suspected to be a glass injury, I
Yes, ma'am.
think it's wise to do a CT.
Okay, ma'am.
As we previously
Thank you, ma'am.
mentioned, yes.
Sir,
Good,
over to you.
good morning. Thank you, Rakesh.
My topic is the managing aphakia post-traumatic cataract surgery by second year. You have seen the nicely managed traumatic surgery. So you may end up with some multiple traumatic cataract. Trauma can affect the lens in several ways. Ocular trauma is relatively common. 1/5 of the adults will experience ocular trauma at some point of time. Various ocular structure can be damaged, as we discussed earlier, that you need all comprehensive glaucoma, cornea, and retina specialists together. Injuries may lead to other ocular disorder through various mechanisms. I am going to cover
Just
one or two
one presentation. Session is
videos and techniques for the managing the post-traumatic cataract surgery, aphakia management. Early and late traumatic cataract surgery and IOL implantation after open globe injuries have no significant difference regarding the post-surgical best corrected visual acuity. So you can plan either simultaneously or later on. Type and optimum placement of the IOL is the most important, because sometimes the visualization is poor, more vitreous loss, and posterior capsule is compromised. So considering the placing the IOL in a later secondary procedure, it's sometimes beneficial because then you know the structure well. There are the multiple options. You have the iris claw, you have the scleral fixator, or you can have the glue. I prefer mostly the iris claw. I am going to show you one of the animation, how simple is the iris claw. You get usually, you give two side port incision 180 degree. This is the main incision. Do anterior vitrectomy, put the tricot and do good anterior vitrectomy, whether at the same time or at the post aphakia. Then put the pilocarpine, so the pupil is constricted. Deepen the chamber with the good viscoelastic. It is just to show how simple is the iris claw. You have the claw, check the claw whether they are open. Put from the main wound, rotate to the 180 degree. Lens holding flopsy. Grab from the side, which side you have to enclave. It is the important that you hold firmly the lens, because when tucking, it will go down. Again refill. Hold from the other side and hold firmly the lens, so that you can very easily, and the surgery is completed. So you can see that in traumatic cataract how simple it can be. This is one of the such case. Haptic in this type of the cases is attached to the main mid periphery, where normal vascular supply and nerve supplies will not interfere, and allow the pupil to unrestricted dilatation. Sorry. I will just fast forward. This is surgery side port, what we have shown. This is the main port, separating the iris from the wound. Then the vitrectomy, tricot. Yes. Okay. Viscot. And put the iris claw. In the same way, just short video is a traumatic cataract. Same view. I will just skipping the glued IOL because its time is short. Separating the wound. Cutting the adhesion. Enclaving the iris claw. And then making the pupilloplasty so that, and here we have not done the multiple suture, only 2 suture, because the iris is much traumatic and avoiding stretching more on the iris can lead to the dialysis and you can complete the surgery. So thank you, friends. I have skipped because of the time, paucity of the time that glued IOL. I was having the video, but our instructor has the shortage of time. So thank you, Rakesh. Thank you. So my importance is for the iris claw. I try to use iris claw as much as when there gets chance. I will shift to the glued IOL when I don't get the chance to enclave the iris. Thank you.
Thank you, sir. You nicely covered. And so I would like to call all the speakers to the chair for the photographs. And I will actually call the others for the other session, other chairperson. So actually we conclude the session. It was very good session for the about the traumatic cataract. So there are the various. So I skip my the presentation